Hi everyone, thanks a lot for your interest in this study. We're going to talk to you today about the Coronas project and specifically about the study we did to identify the mental health research priorities for Western Australia. I'd like to start by acknowledging the Aboriginal people of the many traditional lands and language groups of Western Australia. We acknowledge the wisdom of Aboriginal elders, both past and present, and pay our respects to the Aboriginal communities of today.
I'd like to acknowledge the people of the lived experience community who taken part in this study as well. We wish to acknowledge the collective expertise of people with a living or lived experience of mental health challenges, and we recognise the important contribution that you have made and value your courage to share this unique perspective for the purpose of achieving better outcomes for all of us.
So to identify the mental health research priorities for Western Australia, we conducted a Delphi study, and that involved generating items for the Delphi survey, so specific research questions that the community believes, if they were answered, would have the biggest impact on the mental health of Western Australians. We then administered the Delphi survey to expert panels. So we had two panels. We had an expert lived experience panel and a mental health professionals panel. So that was healthcare workers, policymakers, and mental health researchers. We then collated and shared the responses with the panels and updated and re-administered the survey to allow panels to revise the responses in light of any feedback. Hand over to Viv now to talk about our process of developing the Delphi study.
Hi there, I'm Viv. So as part of our journey last year, we had a team of Curtin extra psychology students who went above and beyond, and they actually helped us review the literature to help develop an initial list of items that we used in the Delphi study. But more importantly, we consulted with a number of stakeholders out in the community to try and understand the research questions and topics that matter most to people with professional or lived experience of mental health challenges. So we conducted reference groups, consultation meetings, and an email call out through various mental health networks, just to invite everyone's feedback on potential research principles or priorities for the project. We amazingly heard back from over 200 people in WA, which included researchers, people from health services, non-government organisations, as well as clinicians and policymakers and consumers, carers and peer workers. We then actually went about recruiting panel members for the Delphi study, and that occurred during May to August last year. And participants who were identified as consumers, carers or professionals, as Pete mentioned before, were invited to sign up to the study as well, and they used a program called Delphi Manager to complete the study as well. After recruiting our panels, we actually conducted 3 Delphi survey rounds. So just go to the next slide and you can see the makeup of what it looked like for the Delphi study. Yeah. So like Pete mentioned, we had 2 panels, so one for people with lived experience and one for people who identified as mental health professionals. Now we know that people can have both lived experience and also be working in the mental health area. So we actually just let participants choose which panel they'd prefer to be a part of for this study. As we mentioned, we conducted 3 rounds of the survey, so people could vote whether they how important they felt the priority was to be researched. And then if only 70 to 79% of people felt that it was a priority, it actually went into a second round for the survey and people had the opportunity to re-rate again. If after that, over 80% of the panels actually felt that it was a priority, then we included it as a priority. And for any priorities that were really less than 70% endorsement from both panels, we excluded. In terms of what the survey covered, we looked at research principles, so how research should be done. We looked at general mental health questions, which apply to many of us, but we also had specific mental health questions that might be relevant to particular groups or topics. So I'll show that on the next slide. So these are just the different areas that we had involved, and there were about 23 different areas. So it was a very, very broad study.
Hi, and I didn't introduce myself earlier. My name is Jonathan Bullen at Curtin Medical School. So talk you through, I guess, the groupings of the participants. We had just under 200 EOIs received. 120 took part in round one of the Delphi study. And this was split, reasonably evenly between lived experience panel and the professionals panel. Slightly fewer lived experience panelists of consumers and carers. Majority of those were consumers, roughly a third were carers. And some of those in the broader group had formal qualifications in mental health as well, as Viv touched on in the previous slide. For the professionals panel, there's researchers, clinicians, policymakers, and there's a split between those, with roughly half having a lived experience as a consumer and or a carer as well. Going back to that choosing which bucket you're in that Viv spoke about. In terms of demographics, you can see there's a mix of all sorts. Slightly above parity for Aboriginal Torres Strait Islander backgrounds with the 5%, as opposed to a roughly 3% population. The largest proportions here were multicultural backgrounds, LGBTQI, alcohol and other drug issues, and then a smaller number for the other categories that you can see there. Lived experience panelists, excuse me, who chose to disclose this information typically were within the depression, anxiety, PTSD, and the other groupings you can see here. And for the professional experience panel members, they typically fell into these broader professions categories, starting with psychiatrists, psychologists, nurses, GPs, and moving on through. So quite a broad range.
So for the Delphi study, we started off with over 1,000 items across those 23 mental health areas to rate. So it was quite a laborious task for our panelists to get through the first round of rating each of those priorities. In the second round, 18 additional items were provided by the panelists from round one. So they were rated in round two, along with any where there was not consensus in from round one. After the third round, we ended up with 608 items reaching consensus. So that was 576 specific research questions across those areas, plus 32 research principles. That is how research should be done. So we ended up with many priorities endorsed by our lived experience and our professional panels.
So in terms of the research principles that Pete just mentioned, we're really looking at, I guess, the how of the research process, how we go about doing this. And as you can see from this word cloud here, there's significant focus on a couple of areas, but particularly co-design, collaboration, and that idea of the values that will drive the research in a way that provides meaningful research process, translation, and impact for the end users. And there's a big focus on whole of person, so this idea of a holistic well-being focus.
So this is a very busy table, so I'll draw out a few points from it. Down the left-hand column, we have all the different areas that the Delphi study had items within. The second column here is the number of research questions we had within each area for panelists to rate. The third column is the number of final priorities that were endorsed within each area from both of our panels. The fourth column is the average or the mean rating across each area. And as you can see, they're all rated in the sevens out of 9. And the window is very narrow. So they're all rated as important. In terms of the number of priorities, obviously those areas that started with a greater number tend to end with a greater number. So domestic and family violence had the highest number, followed by mental health conditions and Aboriginal and Torres Strait Islander mental health, homelessness, and older adult. And if we look at the mean rankings, Aboriginal and Torres Strait Islander mental health was the highest ranked, followed by perinatal mental health, clinical pharmacology, psychological therapies, and sexual trauma and unwanted sexual experiences. So just to give you a few examples of the specific research questions that were the highest rated priorities within each area, for Aboriginal and Torres Strait Islander mental health, what are the most effective ways to improve understanding, prevention and responding to self-harm and suicide? And suicide actually was amongst the highest rated items across all areas. So there was certainly a theme there. Perinatal mental health, what are the effective ways of increasing awareness of treatment of perinatal mental health among vulnerable groups such as cold, rural and remote, homeless and Aboriginal peoples? And this item really touches on the intersectionality, which was another strong theme, that a lot of the priorities really touch on a whole range of different areas, populations and priority groups. I'm not going to go through the highest ranked items for each area, but the slides are available and will provide more information for people who are interested in more detail at the end of the presentation. But just to let you know that there are priorities identified across each of these areas. So I'll hand over to Viv now to talk a bit more about the themes.
So as you've just seen, we identified a lot of research priorities, over 500 in fact. So after completing the Delphi study, our team also conducted a qualitative content analysis to help summarize the research priorities identified. So we started theming some of the priorities together, and we identified 14 themes from the research priorities. And these are all summarized in this slide here. And as you can see, the services theme popped up the most, with almost half of the priority items covering that theme of evaluating services and also the development of services for people to address mental health issues as well. And then this was followed by prevention, early intervention, detection and health promotion, as well as intersectionality, which Pete mentioned before as well, and that was a really important component of this project too. Determinants of mental health, and then also translation. And then when we look at the mean ratings for each thing, you'll see that they're actually all very similar as well, because everyone identified these areas as a very important part of addressing mental health research. But the highest mean ratings tended to be in the theme of suicide and self-harm, followed by co-design, capacity building, trauma and translation.
So we have uploaded a full list of the priorities in an Excel spreadsheet and a preprint manuscript that describes these findings at this link here if people would like more detailed information.
So just speaking to some of the some of the conclusions that we've come to through this work, we now know the mental health research priorities for the WA community. WA mental health research strategy needs to build capacity to address as many of these priorities as possible. And I guess the questions are, where do we start? Obviously, there's an enormous body of, areas that are possible and how we might go about doing that. The questions that have, been raised through this work are: do we leverage existing strengths? Do we leverage unique strengths, whatever they may be for the WA populace? What will attract more national, funding and co-funding to WA? What are the areas of most local need, and also the funder priorities? But some of these things will have a circular relationship with one another in some ways. The existing strengths or unique strengths may become funder priorities, for example, and vice versa. So we've got to look at it in that way. It's probably worth mentioning as well with Aboriginal and Torres Strait Islander social and emotional wellbeing, that we know and have been advised through this project that the priorities for the Aboriginal and Torres Strait Islander population are very well known. I think one of the things, so we're very cognizant of that, don't want to reinvent any wheels. What we do know is that, and what this work perhaps introduces, is a really broad understanding, going back to Pete's discussion around what was the #1 mean ranked priority, and that was Aboriginal and Torres Strait Islander mental health. And that's come from a really broad, that's not just Aboriginal people speaking to that, it's a really broad group of individuals and professionals and lived experience individuals who have placed this there. So that's really encouraging. And now it's a question of, well, where do we start? How do we leverage this knowledge and this groundswell of support for these things for various areas to really make a difference?
Thanks, John. So this project was completed to inform the development of the first Western Australian mental health research strategy, which was drafted and submitted to the Department of Health in December 2021. And the question we had really was, how can the strategy build collective gain across the sector from partnerships and collaborations to really optimise consumer outcomes? So what we had at the forefront of our mind was the need to prioritise consumer voices in this process, was to build capacities, both consumer capacities to contribute to the research endeavour, to make sure that we're doing research in areas that are important, and our Delphi study can now provide the evidence for that, but also research capacities for the whole sector, not just researchers, but the whole sector, building consumer research capacities as well, and healthcare worker research capacities. How can we build the infrastructural platforms that will facilitate those collaborations to occur and the data collection to occur that's needed to address these very important mental health issues? We need to build some support for burden of disease research so that we know what the priorities are and what the main mental health problems are that people are grappling with. We need cause and effect research that tells us about what mechanisms are contributing to and maintaining mental health challenges. We need funding for prevention and intervention research so that we can use all that knowledge to actually make a difference on the ground, and translational research so that we're not just learning within the context of trials what works, but implementing that in the real world to make sure that it has an impact on the ground. We thought that it probably made sense to initially focus on priority areas of existing strength within Western Australia, while with a little bit of support, a lot more co-funding could be leveraged nationally, and then build broader capacities in those other priority areas, and areas in which WA has strategic advantage. So, for example, rural and remote mental health research. We thought Western Australia was really uniquely placed to do some really innovative and important work in that space and in others. So that's our summary of the Delphi study. We did just want to finish off with some acknowledgements of everyone who helped us with this work. It was a real sector-wide collaboration, and we're very appreciative of the time that everyone contributed to it. Our professional advisory group, who started advising us back in September 2020 throughout this work, and will continue to do so as we transition into the strategy. I wanted to acknowledge our lived experience advisory group, who also advised us throughout this work at every stage of the work, and the team that really led the Co-ROMAS project. I really want to acknowledge Ben Horgan, who was going to be with us today, but at the last minute, unfortunately, was not available for this presentation. But Ben co-led this whole research program, was fundamental to it. And for those who don't know Ben's a consumer and community involvement advocate. And I learned a lot, and I think we all learned a lot from him throughout this whole process. So I certainly wanted to acknowledge Ben's involvement. So thank you very much. That's the end of this presentation. We have other presentations and other components of the Co-ROMAS work as well, if you're interested to find out more. And we look forward to this work having